Good morning, all. As you arrive, welcome, and hope you've got your thermals on. We're just admitting some people at the moment, so good morning, Wendy. Thank you for the nice welcome. That shows that you can see us and hear us. So still quite a lot of people being admitted. Right, so there's no one in the lobby now, Nina.
Okay, so we can start. Good morning, everyone. A warm welcome to all of you. My name is Nina Khazaezadeh. I'm the Regional Chief Midwife for London. It's a pleasure to be here with you today. I will be chairing the webinar today, and I just wanted to start by setting just a very brief context. Every day in London, approximately 12 babies are born to mothers who smoke. A reminder of the need for us as a collective group to support expectant parents to a smoke-free start in one of the life's most transformative events, and that's the childbirth. We know the foundation of a child's life is set as they start. So a smoke-free pregnancy and birth is one of the most impactful steps that we as a collective group can take to give every child in London the very best possible start in life. But we recognise that quitting smoking is not easy, which is why we have brought to you a wide range of experts today to share their insight on how we can best support expectant parents. So before we start, I'd just like to take you through a couple of housekeeping points. And that is to let you know that we are recording this webinar today. So you will be able to access it later on the London Tobacco Alliance website. If you don't wish to appear on the video, feel free to turn off your camera, but we would really like to see you because that will make the session more interactive. There will be a number of speakers throughout this webinar, so if you have any questions in the meantime, please do type them in the chat function. We will do our best to collect them and during the QA session to answer all of your queries and questions. And with that in mind, I'd just like to invite our first speaker, Tracy Parr, who's the Programme Director for London Tobacco Alliance and Stop Smoking for London. Tracy, welcome, and over to you.
Thanks so much, Nina. And we're delighted to be here today. This is a brand new campaign week for London. It's the first time we've done it. We've already had lots and lots of support for the campaign and lots of people contributing. So many thanks to all of our speakers today and to Nina and others who've been filmed to help us with the campaign. And an absolutely huge thank you to Claire and Noah from Action on Smoking and Health, who've helped us to manage this webinar because we have issues managing a webinar of this type on our the Tower Hamlets where we're hosted website. So thank you to them, and I look forward to hearing from the speakers today. I just wanted first of all to just give an overview of the campaign week. If we could just go to the next slide, please. And just a bit of background for people who may not be aware of the kind of pan-London tobacco work that we have going on. We have the London Tobacco Alliance. We are a strategic partnership organisation aiming to make London smoke-free by 2030. And we work with colleagues such as Nina in the NHS, such as our colleagues from ASH, local authorities who fund us, the GLA, London councils, voluntary sector organisations and OHID. So we bring our partners together. And Nina reminded us that there are 12 babies a day born in London to mothers who are still smoking. And we're not planning today to go through all of the impact of that. The films that we have and our website very much points to that. But we've worked together, and it's just great to collaborate and develop something new that raises this issue in London. Because with many issues such as this, when people say, well, the smoking at time of delivery rate is only 3.9%, but we have to look at those individual babies that are affected. And as Nina says, that's 12 a day. So what did we want to do with this campaign? We wanted to raise awareness of the impact of smoking during pregnancy and support pregnant mothers and people who are attempting to become pregnant, to give them information. And then the reason for this webinar is to raise awareness amongst healthcare professionals and partners of the issue and to encourage discussion. So if we go to the next slide, I'm just going to take you through some of the materials we've got. So we will send these slides out. If you go to Stop Smoking London, and someone will put that please in the chat, a link to the London Smokefree Pregnancy page on Stop Smoking London. It is this week. We've had lots of positive impact, as I say. We've got a number of films. We've got Annika, who talks through how she gave up smoking when she was pregnant. And Nina has done a film too, talking about the harms and how parents want to give people the best start in life. We've got Baski, who's a fetal medicine consultant from St George's, talking about the impact and why it's important for mothers, but then ending up with Patience, who's a consultant public health midwife, talking about the help that's available and how there is tailored support, because this is an addiction. It's a difficult addiction to give up, and very much the message is that this is a supportive environment for pregnant women and their partners. Next slide, please. So what we have on the landing page, this is a guide to quitting smoking during pregnancy, which is a new guide which is downloadable. And that's our landing page, just alerting people to this week. And as I say, if we go to the next slide, we have had lots and lots of people supporting on social media. We've got Southwark there, we've got Hounslow, Lambeth, Merton, Greenwich, North Central, South East, Camden and Islington. Lots of local authorities and ICSs have been retweeting our messages on social media. We would encourage you, if you are on social media, to go to Stop Smoking London and retweet some of the content. Please use the hashtag there, which again we'll put into the chat. But just to say a warm welcome and thank you. I'm going to hand back to Nina now.
Thank you, Tracy. For setting the context and the scene, it's really great to see all the work that has been done in London. So as promised, we have a wide range of experts who are going to give us a bit more information about how we can, as a collective group, support parents that we interact with and come into contact with. So just want to introduce Jane Coyne, who's a Programme Director in National Smoke-Free Pregnancy Incentive Scheme, an Associate Director for Population Health, and then NHS Greater Manchester. So Jane, welcome. Jane's going to talk to us about a pregnancy incentive scheme and vapes by pregnant women, that a project that they have undertaken in Manchester. So welcome, and over to you, Jane.
Oh, thank you, Nina, and thank you, Tracy, for inviting me today. I think obviously I know quite a lot of people in the smoke-free pregnancy world. I've been around quite a while, and I'm obviously a midwife, so I understand all the challenges you've got in delivering some of this. And it wasn't until I came to GM in 2018 that really understood the challenges that smoking really brings to pregnancy and those families beyond. I think once you get into tobacco, doesn't it, it sucks you in and you can't let it go. Yeah, I'm happy to move on to my next slide if that's okay. So I think the first element of this is I've come to talk to you around the challenges of smoking in pregnancy. And I know a lot of you will know this, but I think it does help to really revisit this and just remind ourselves why we do the jobs that we do. Next slide, please, Claire. So smoking still remains the single most modifiable risk factor in pregnancy, and that means that is something we can do something about. There's lots of conditions and lots of things that as midwives and doctors and people who work with pregnant women, we can't change. But obviously for smoking, that is something we can actively reduce those harms. And at the minute, at least 7.4% of women were still known to be smoking at the time of delivery, and that's above the original national ambition that was set for 2022. And the challenge around that is, and I think Tracy kind of alluded to some of that just then, is that sometimes SATOD can make us feel a bit comfortable that we feel okay and it's really low. But actually in some of our communities, we could have smoking rates of 20%. But because the wider community don't smoke, it gives that lower number. And I think that makes us feel kind of better that the work we're doing is working. But I think sometimes we've really got to get down to that locality and neighbourhood data to really understand what our SATOD really looks like for us. Thanks, Claire. So the impact of smoking, this costs our NHS over £20 million a year, and that's kind of some old statistics. We did some data in GM in about 2021, 22, and we did a spot check audit just on 4 maternity price points. I think it's about 20 across the maternity system. And in GM in a year, we probably spend about £15 million a year on our smokers. That's those additional scans, those extra appointments, those premature births, those neonatal nights. Realistically, this is a significant cost in a time when we need to kind of save as much money as we can, isn't it? And make sure that's directed to the kind of care we want to give. Smoking, obviously, as we know, exposes women to more chances of low birth weight, preterm birth, miscarriage, stillbirth, and obviously sudden infant death. In some of the national CDOT reports, we find that smoking is probably in the majority of those deaths in child deaths under the age of 1. And the midwife in me still remains quite shocked by that. Children born to mothers, obviously it doesn't stop there, does it? When children are here, then we have asthma, diabetes, learning difficulties, we have problems with hearing, and often more likely to grow up to become smokers themselves. So then we have that intergenerational cycle of smoking that obviously through all this work, we're really trying to break down those barriers. And I think when we talk about cost of living, obviously this is actually another thing that's pushing those families into poverty. How much can they save? And I think we had the chief midwife and the deputy chief public health up to GM last week, and we were talking to some mums, and the mums were saying this actually, by quitting, there was so much money went back in their pocket for other things. And I think we've really got to make sure that families understand that, as well as dealing with their addiction. And obviously just recognising the majority of smokers do come from those lower deprived backgrounds. So this is another reason why we should be putting more money back into their pockets, as well as reducing their infant mortality rates. Thank you. Next slide, Claire. So the scheme, what we're going to do about that. So this is based on multiple schemes that kind of began probably early 2000s. I think Blackpool was the first site that they trialled an incentive scheme, and over the years have been rolled out in lots of areas across the country. And in GM, you can probably move on to my next slide, Claire, if that's okay. We've had a scheme that's been funded now since 2018. And I think they're there to reduce inequalities, but I think what we often hear from the women is the hook that kind of gets them into service. So that idea of being given some money, given some financial support has been really good in keeping them and getting them engaged with services. Obviously, this national scheme is now funded by the Office of Health Improvement and Disparities, as part of Department of Health. And obviously that's, I'm working with Accenture at the moment, who've been our digital partner within that. And anybody who's eligible can be offered the scheme. So it's not, kind of blanketed. Any sites that are ready to go and can deliver will be there to offer the scheme. And since we started our scheme, because people say, do you know that this works? We've reduced our smoking at time of delivery rates. Actually, if I looked at the quarterly data, it's probably over 50% in GM since we started. And we know through our digital platform, we've saved over 6,000 smoke-free babies. And that kind of makes me feel all warm inside, because they're babies that might not have been here with us today otherwise. So I think, when we look at why do these schemes work, is that because we know we get smoke-free babies on the other side. Thanks, Claire. So incentives, obviously, they don't work on their own. So obviously there is some degree of somebody given something will kind of encourage some quitting, but this works intrinsically as a whole system approach. They're kind of not a reward, but you say they're supporting people in challenging times. And like I said, my mums last week were very clear on, I think somebody was on Granada TV, you probably don't get our northern television in London, but she was kind of talking about she didn't struggle for getting her nappies and things together for a baby and some baby girls, etc., because she felt the vouchers were supporting that, and there is a return on investment for us as the NHS for £4 for every £1 spent on incentives, which is phenomenal, isn't it? Obviously we don't necessarily see those cashable returns, but it means we've got release in time to care and we've got funding that we can funnel in other directions. And they're just significantly known to reduce smoking in pregnancy and allowing families to take control of their own health and their addiction to tobacco. Thanks, Claire. So what does this include? So it means we do a CO reading at every contact, making sure we have contact with every smoker, and as midwife, should I say, not just in our incentive programme. Obviously, we do opt-out referral to stop smoking service, so really making sure women get really good VBA, they really have those really deep conversations and that they understand when they leave that midwife, this is really important for them to attend that appointment. And if you can make that appointment while she's with you, we found in GEM they're more than likely to kind of come and attend that appointment as well, which is really good to kind of manage that attrition rate when you hand over to services. Obviously, we want to include stop smoking support and treatment, and that has included the use of vapes. Probably for about 2 years for us now, we've included vapes as part of our toolkit, which has been fantastic. We do a risk perception intervention. That's a really hard-hitting motivational interview after the booking scan for those who are still smoking. We have a data platform for our data analysis, and obviously we use incentives. So we're offering that whole toolkit approach to somebody who comes and sit in front of you, because as you know, not one thing will work. It might be a multitude of sins that will actually get people to get that quit and beyond. Thanks, Claire. So how does it work once you get the incentive? Obviously, they'll be sent over to, it could be your in-house maternity tobacco dependency service, might be local authority stop smoking, might be a third-party provider, might be a digital app. There's lots of ways that people can access stop smoking support once they leave maternity services. And we're in the process as a team of onboarding all those people now. But obviously, they won't have to come to every appointment, and that's weekly for the first 4 weeks and then monthly to birth. And there's 2 postpartum appointments as well. And they must provide a CO verified quit, so that's a 3 parts per million or less, and the maximum they can receive is about £400 if they get to that 3 months postpartum, which for a lot of women report that is a phenomenal amount of money to really help them get started on their way with supporting their baby. They're allowed to relapse once on the scheme, so they can join us, they can relapse, and then we'll pop them back on. If they did relapse again, that obviously doesn't remove the stop smoking support, it just means they can't come on the incentive scheme. We record all our information on our digital platform, and obviously they'll be given a Love to Shop gift card, and then obviously with the gift card that means the amounts they're going to spend can add up on there. They're not having to just get £20 and then they can't stock, so that accumulation allows them to buy bigger items. And the scheme currently is supporting any woman who's going to be enrolled up to the March 25, and then we will support them up to that postpartum period up to March 26. Thank you. So the digital platforms, it's a really bespoke digital platform. It's something we've had in, it's kind of a slimmed down version of our GM one, and this will register participants. It will automatically issue the vouchers, so it's reducing some of that administration burden for our staff. And as you can see there, people are saying the vouchers have been a great bonus, and plus the money they're not buying from tobacco. And these are really things we can obviously get that anecdotal qualitative feedback, and also use the platform to really look at our data behind that sits behind that as well, to understand if our interventions work or if we need to put anything else in place. Thanks, Claire. And it's just that reminder, they boost morale. There is nothing better, I think, for a woman coming sitting with their advisor and showing that they're smoke free. You can see women actively beaming and really being really proud. And it might be the first time in their life that they're succeeding with something. They get a certificate for being 4-week quit. They're just absolutely leaving you buzzing and excited that they're doing this. And I think that motivates them to keep that going. And then that spreads, doesn't it, amongst our families. So we then get grandma, granddad, mum or dad, or, other family members who might be in the home looking at that as well. So it's really important that, we really give them that buoyancy of, this is something that's really difficult and challenging, isn't it, coming over addiction to tobacco, and we know that it can take 30 attempts sometimes to be quit. So if this really helps get women over the line and you say they feel empowered to take control, I can't think of anything better that we can offer. Thanks for that. So I suppose Jersey just asked me to touch a little bit on GM, and I suppose some of my slides probably cross over a little tiny bit, so I might skip on a couple of these, but you can go to my next slide, Claire, if that's okay. So GM, we have 10 localities, 2.8 million population, and we face some of the highest smoking rates and of deprivation in the country. And we knew we had a key driver in our programme to really make a shift in that. And I think the thing that really made the difference for me is the TDA teams. And we moved to an in-house service across all our localities, which is employed MSWs within the trusts from 2020. And I think the real thing that came through from the women last week, and I've constantly since I've led the programme, is that the advisor makes the difference as well. So everything in your toolkit is amazing, but having that continuity of care, that same advisor, that person being throughout there, sending those little texts saying, I think one woman said, you know, she just texted me and said I was amazing. Nobody ever gives me that positive feedback. And I think if you're a stop smoking advisor on the call, you're doing an amazing job, and just keep doing that. The women absolutely adore you. Thank you. My next slide. And I think just was our whole system approach, but I think I've kind of touched on that in the national slides, but exactly the same. This is our bringing everything together, and just to show that one bit doesn't work in isolation on its own. My next slide, Claire, please. And I just wanted to share our SATO data. You know, I think this is when I said, how do I know it works? So this is GM. I think we started when we were about 12.6, 12.8 back in 2017, 17, 18. And then literally in Q1, we were at 6.4, and Basel was just over 6.4. God, I can't quite remember. Sorry, I'm having a HRT moment. But I think obviously we've crossed England now. We've really seeing that downward trajectory, and that's even working throughout a pandemic. I think that slowed us down a little bit, but obviously, absolutely it's there. So, and this is the lowest we have ever been. Thank you for all your support. I really appreciate that. And obviously now we've moved our ambition to 4% by 2028. So really, as the Vanguard side, I'm really pushing them to kind of get that smoke-free generation done before the national team. Thank you. Next slide. And I think the biggest thing I wanted to touch base on is using vaping. And I think there is so much uncertainty and misinformation about vaping. But for us in GM, we knew that 40% of women came to our programme vaping. They were either using their uncles or their dads, or something they'd bought off the market, or something that wasn't suitable, or they were making their own liquids, for costing, etc. So we knew that this was another form of nicotine replacement therapy that we were really going to see some good quits rate with. So we work with a couple of providers in GM to make sure we have a proper offer of a safe device of industry standard liquids. And obviously we're just utilising Swap to Stop this year as well, because I think why not, while you're being offered something, take it. And I think it's about listening to women, isn't it, for the use of vaping, is that they want it and it does help them quit. We know it's 5 times more effective, and it's just having that in your tool bag and being able to say, has this worked? Has this worked? Right, you've had an RT, right, you've had a vape, what else can we use? And really being able to offer that full repertoire of medication. And I think when women are using vaping, they also reduce the amount of NRT that's required. I mean, women in pregnancy, we tend to see don't use lots of NRT anywhere, but obviously but it's quite costly. So we have seen that cost reduce as well, where we've increased vapes quite significantly. It's received well by pregnant women, and it does increase the number of quits and successful quit attempts that you'll see in your service. Thanks for that, Claire. Thank you. So I put my email on there. More than happy to take some questions now, or you can email me outside of this for anything about GM related, or the National Incentive Scheme, or we do have a National Incentive Scheme inbox if you've got any questions there as well. I'm sorry if I've been a bit over my time, but thank you for giving me the chance to come today, Tracy.
You're not over your time, actually.
I know. I was going to say that's impressive. That a large amount of information, and thank you for sharing your approach, Jane. And you are actually left us with additional time, and I'm sure you will stay with us for the Q&A session. So I'm just encouraging colleagues who are joining us on the webinar to type your questions to the chat function, and Jane and other experts and speakers will stay with us to address all of your questions. And it's really interesting, Jane. I mean, congratulations on what you have achieved, and it really does show a personalized package where you have a number of tools to support parents is incredibly important to support them with a success. And what stood out for me is that the risk of relapse, and actually making it clear to parents that, and the expecting parents that it is common, and don't give up. And I think that's a really key message to take home. So, but thank you. And next we have a Peter Hajek. I hope I am pronouncing your surname correctly. If not, do please correct me. A professor of clinical psychology, Waldron Institute of Population Health, Queen Mary's University of London, Welcome, Peter. I know you're going to share with us some of the findings from the study on vaping in pregnancy. So over to you.
Now, Peter came in, and I'm not sure, Peter, if you came in on...
I'm not
there you
in.
are. Fabulous.
Yes. Now, can you see my screen?
Yes, we can.
Yes.
And if I do this...
In the presentation mode, that would be
Do
wonderful.
you see the slide?
Absolutely. Thank you.
Oh, excellent. All right, guys. So I was asked to tell you a bit about safety of vaping in pregnancy. And I'll be talking primarily about the trial we did, which we called PrEP trial. I'll briefly mention what was already known about effects of nicotine in pregnancy and then tell you a bit more about what that study showed. So something you all know on this forum, the major effect of smoking on pregnancy is association with prenatal growth. So babies grow slower, higher incidence of low birth weight, low average birth weight, small for gestational age, and stuff which is associated with restricted prenatal growth, premature birth, and stillbirth. And this is clearly causal. If we had more time, I would take you through why we know this is actually causal. It's caused by smoking. There are some other associations, miscarriage, sudden infant death, birth defects, behavioral cognitive problems, but there the strength varies from study to study and is also not quite clear about the causality. Smokers have higher drug use, stress, mental health issues, poverty, and so on, and all these things are contributing to these other things as well. So for that reason, I'll be focusing primarily on prenatal growth and baby's weight. That is the crucial indicator. Did I switch? So how do we know how nicotine contributes to these things? So we know that smoking causes it. If nicotine is involved, that would mean that nicotine replacement treatment and vaping, and nowadays pouches coming along, they would be dangerous too. Where can we look? Well, we can look at trials of nicotine replacement treatment versus placebo. And the largest trials done on this and the highest quality from Nottingham actually didn't find nicotine patches effective in helping women stop smoking. It did find an effect on reducing smoking. But nicotine arm had better birth and infant outcomes than placebo arm. And then they followed them up through 2 years postpartum, and they were still had better outcomes despite using nicotine patches. Regarding snus use, that's another very good test because snus users take more nicotine in than smokers. And if there was negative effects on birth weight, then that could still be due to tobacco because there's nicotine and tobacco in snus. But if there is no effect, then that exonerates nicotine. It would show that the effect is primarily due to carbon monoxide, which is what everybody thinks anyway, and possibly some other stuff in tar, what's called tar. And there's a number of studies looking at Swedish snus is used widely in Sweden, and they have population data. It's not just samples, it's the whole population. The earlier studies showed lower birth weight in women who use snus. But that was in the times when snus had a similar role e-cigarettes have nowadays, that people, pregnant women, smoke and then they want to stop smoking, so they switch to vaping. That was happening in Sweden. They were smoking in early pregnancy, which could have explained that effect. They have still better birth weight than smokers, but a lower birth weight than never smokers. Newer studies didn't really show much of an effect of snus. And the most important study is of siblings which differed in snus use by their mothers during pregnancy. And you would have thought that would be rare, a woman having 2 children and she used snus when she had one and not when she had the other. But actually on the population scale, they found 4,000 such pairs, and there was no effect of snus use on birth weight. So that is reassuring. Regarding e-cigarette use and pregnancy, there is one study which reports more what they called abnormal reflexes. In newborn babies, reflexes are checked, and those of smokers and vapers had some indicators which babies of never smokers did not have. Could be due to nicotine, could be due to familial effects, or it could be because practically all these women smoked in early pregnancy. This was 2020, and all these women were like our women are nowadays. Most of the women you see using e-cigarettes in pregnancy, they use them because they smoked previously. The PATH data, that's a large follow-up survey of people in the United States, and some of them are smoking, some of them are using e-cigarettes. And the new data didn't find any effect of e-cigarette use on adverse pregnancy or birth outcomes. And there is a large cohort, and that's from last year, looking at low gestational weight gain according to product use in the last trimester of pregnancy. And here, no nicotine users and vapers were the same. Smokers and dual users had higher risk of these things. And this would be cohorts of young women in the States where young people hardly smoke at all. And it's possible that all these vapers now are people who actually never smoked. So again, that's sort of reassuring data. Now, this is the trial I was going to tell you about. It was a randomized controlled trial of e-cigarettes versus nicotine replacement treatment versus patches. And it was very large. A number of NHS units and universities collaborated on this. And there were 2 issues which I need to warn you about. We tried to validate self-reported smoking status by posting these women, because they were all over the country. We sent them sampling kits for saliva. So they were supposed to get saliva into these little tubes, read the instructions how to do it, then wrap it up and take it to the post office. And if you just had a newborn baby or you're in very late stages of pregnancy, we discovered people just wouldn't do it. And so we had very low return on that, which of course, if you then only look at validated quit rates, you get very low numbers. We also found what was sort of could be predicted, that women who were given patches and didn't manage to stop smoking, and they still wanted to stop smoking, they would then naturally also try vaping. And so quite a chunk of people who successfully quit smoking, who were randomized to patches, actually quit with e-cigarettes. And so the statistics need to take care of that. So here are the results in terms of smoking cessation in these randomized groups. If you look at validated sustained end of pregnancy quit rates, they're very low because very few people return these things, just on the borderline of significance. But if you exclude those who quit with e-cigarettes in an RT arm, and the other way around, but there was, I think, only one woman who was allocated to e-cigarette arm, but you quit with patches, then you get it significant. But if you look at self-reported, which is probably much closer to the real quit rate, then the difference is quite high, and e-cigarettes sort of doubled the efficacy of patches in this sample. Now, regarding the safety, low birth weight was more common in people using an RT, which was almost certainly, it was not because e-cigarettes somehow prevent that, it was because they prevent smoke or stop people smoking. So because they've had higher quit rates, they also had lower incidence of low birth weight. And there were no adverse birth outcomes differences in anything else. Now, this PrEP2 study, this time we looked at outcome based on nicotine use rather than on randomization, because you understand that even if you randomize people, some people actually use the opposite of what they were supposed to use, but many people just don't use these products. And you want to assess safety, you want to compare people who did use them and those who didn't. And so we had a sort of definition of regular use. They had to use these products for at least a period of time. And as you can see, this was more common in the e-cigarette. EC stands for e-cigarettes, e-cigarette arm than in the NRT arm. And none of the outcomes differed in those who used patches and those used e-cigarettes, so we meshed them together. And then we analyzed groups of abstainers who didn't use anything, didn't use nicotine, and it was just a small group. Sadly, it looks like not many of these over 1,000 women are able to quit without using anything. Then there were abstainers using nicotine products, and then there were non-abstainers, including dual users. Abstainers using nicotine products had babies with better birth weight than smokers and dual users. And abstainers not using any nicotine, that small sample, didn't differ significantly from either. A regular use of nicotine products was not associated with any other pregnancy outcomes. And importantly, this bit I think is important, there was no difference between smokers and dual users. I'll explain why I think it's important in a minute. Now, a funny finding, which we found in other studies as well, and there are now several published case studies of this, if somebody suffers from upper airways infections and they start using e-cigarettes, they get rid of that upper airway infection. I still wouldn't put my house on that, but it seems to be, increasingly the finding. It's probably because propylene glycol and vegetable glycerol both are bactericidal, and if you puff on them, you kill the bacteria and viruses which causes your coughs and colds and phlegm. But it's an interesting finding. People are often worried about effects of e-cigarettes on respiratory system and the lungs, and here's a finding that actually can help at least with this one issue. So the conclusions on e-cigarette safety would be that, importantly, using these products does not reduce the benefit of stopping smoking. So although there is no question that if somebody switches from smoking to vaping, they will reduce their health risks quite dramatically, are there still some health risks remaining? Would they be better off if they quit without it? Well, they probably would, but not by much, and certainly nothing we could see that would show that using these products when you stop smoking does anything to pregnancy, which makes it any worse than if you just stop smoking and not use these products. And now this is the bit that doesn't increase risk if women also smoke. So one concern, my concern would be that if you give e-cigarettes to pregnant women, those who stop smoking and switch to vaping, absolutely, we don't have any issue there. But what about those who don't stop smoking and vape? And it's called dual use. And we, of course, assume, we know that they will smoke a bit less because they're also vaping. But there is also this issue about, are they now using two sources of nicotine, and could that have any negative effects? In theory, you wouldn't expect that because people titrate their nicotine intake and probably they have the same, and the fact that they vape means that they smoke a bit less. And indeed, this study confirms that. So we don't have to worry. People who are outside the field who think that dual use is damaging will tell you, well, what about the women? You give them e-cigarettes and they didn't stop smoking. And we now have answer to that and saying it actually doesn't do any harm. And even that can reduce the intake of smoke and therefore be good. So what are the implications for clinical practice? Well, clinicians at Stop Smoking Services now routinely recommend e-cigarettes as one of treatment options to non-pregnant clients, and some services have been already using it with pregnant clients also, but there were some, people could have said there is not enough data, and I think we now have sufficient data to be fairly sure that we are not doing any damage and that we can extend the offer of e-cigarettes as one of treatment options to pregnant smokers as well. This is just the people who worked on the study and the various places which collaborated on it. And this is the end of what I wanted to talk about. Now, I may need help on how to stop sharing. Oh, here it is. Stop sharing.
Thank you, Peter. That was really informative and really interesting. The snus is interesting. I grew up in Sweden, so I recognize the prevalence there. So, and there are a number of questions in the chat function for you, Peter, and I'm sure we will all get to them. So thank you to all our delegates who put in the questions. Rest assured, we will answer them all in our Q&A session. So I'm going to move swiftly into our next speaker, John Waldron, who's a Policy and Public Affairs Manager in Action on Smoking and Health, who's going to talk to us about the position statement on vaping in pregnancy. So John, welcome, and over to you.
Thanks, Nina, and good morning, everyone. I feel like I have very little to say after Peter's update and Jane's update. There's not much I can add to that, but I'll do my best. I'm just going to share some slides. Hopefully you can all see that. Yeah, so that's who I am, and I'm going to talk just a little bit about the ASH and Smoking in Pregnancy Challenge Group resources on vaping before, during, and after pregnancy. If I can move this on, let's see if that actually works. There we are. Okay, so I'm sure pretty much everyone on this call is familiar with ASH, but in case you're not, we're an independent public health charity working to end the harms from smoking, and we coordinate a group called the Smoking in Pregnancy Challenge Group, which is a coalition of organisations working to reduce rates of maternal smoking. And our approach consists of national advocacy and campaigning to kind of campaign for measures to reduce smoking rates in the population, and then also practical support and guidance for health professionals working with smokers, and that's where our materials on vaping fit in. And a little disclaimer there, we obviously have no affiliation with any commercial interests, but particularly e-cigarette or tobacco manufacturers. So why are we talking about vaping? And some of this has already been covered. Vapes are currently the most popular stop smoking aid in Great Britain, used by almost 6 million adults. And our annual YouGov surveys of smoking and vaping behaviour found that over half of adults who stopped smoking in the last 5 years used a vape. So, really significant use for smoking cessation in the population. Many women will be starting their pregnancy already using a vape to support a quit attempt, or they may express an interest in doing so during their pregnancy. And vapes are increasingly being used by stop smoking services in the NHS or in local authorities to support pregnant smokers to quit, as in Greater Manchester. And it's really important that healthcare professionals understand what vapes are, their role in smoking cessation, so that they can give evidence-based advice and support to pregnant women who either smoke or vape. There's so much kind of misinformation out there on e-cigarettes, so it's really important that professionals are equipped to have those conversations and feel confident having those conversations. And I've just put that quote from the chief medical officer there, which I think just sums up our position on vaping generally. So if you smoke, vaping is much safer. If you don't smoke, don't vape. And obviously we don't want any children or young people vaping. So just a bit of background on the challenge group resources. So we have just updated all of our materials on vaping to cover the latest evidence and policy developments, and particularly the evidence that Peter just walked us through. And these resources are designed to support professionals to have those evidence-based conversations and respond to any of the kind of concerns and questions that pregnant women and families and other colleagues might raise. And so these resources consist of a detailed FAQ-style briefing designed to support health professionals to have those conversations, a key messages kind of summarized version of that, and an infographic for patients that they can be used to support conversations, but they can also take home with them to kind of, so they have that information to hand. And these are all, the updated versions will be published imminently, so you're getting a kind of preview sneak peek on the session today. And I'm sure many of you have already kind of seen these, but these materials can be ordered for free from our website at that link there, and the updated versions will be obviously available to order as soon as they are published. So key messages from the challenge group guidance. So in the short and medium term, vaping poses a small fraction of the risks of smoking. It's not entirely risk-free, especially for people who have never smoked or for young people, but it's much less harmful than smoking. While licensed nicotine replacement products are the recommended option from NICE guidance, as Peter, expertly talked us through, vapes appear to be more effective for smoking cessation during pregnancy than nicotine patches. We know that vapes in the general population are much more effective for smoking cessation than nicotine patches. And also encouragingly, regular use of vapes or NRT during pregnancy does not appear to be associated with any adverse effects on mothers or their babies. So if a pregnant woman wants to use a vape and it's helping her quit smoking and stay smoke-free, they should absolutely be supported to do so. Unlike cigarettes, vapes don't contain tobacco and don't produce tar or carbon monoxide, which are the chemicals we know are really harmful to babies. And as Jane said, many services, are integrating vaping into their stop smoking offer for pregnant women. And it's important that services are not discouraged from doing this if it's helping women to quit smoking and stay smoke-free. Just moving on. So I just wanted to address a few of the kind of, key questions people will often raise around vaping, and these are addressed in more detail in our briefing. So in terms of youth vaping, we know that vaping is an effective quitting aid for adult smokers, but it shouldn't be used by under 18s, and it's illegal to sell or provide vapes to someone aged under 18. And so if a service were to encounter someone under 18, a pregnant woman under 18 who was vaping, it would be important to communicate that information to them and obviously not provide them with a vape if that's something the service offers. In terms of illicit vapes, we would obviously advise people who want to quit smoking using an e-cigarette to only use legal regulated products, and all of the advice that will be kind of included in our materials refers to legal regulated products, because obviously if something is an illicit product, we can't speak to, it may contain harmful substances, and so we wouldn't want people using any of those. In terms of people who have never smoked using e-cigarettes, whilst, as Peter said, it's probably not massively harmful, it's not risk-free. So someone who vapes and has never smoked should consider quitting vaping, because it's not risk-free and it's addictive and it brings no benefits. In terms of vaping cessation, so pregnant women who have quit smoking through vaping should be advised to keep vaping as long as they need to stay smoke-free. And it's important not to pressure people to stop vaping too soon, because this might cause them to relapse to smoking. So I've heard of quite a few stories of stop smoking services where they say once someone's reached their 4-week quit, they then start encouraging them to stop using their vape. And that's a really effective way to undo all of the great work you've done helping someone quit smoking and make them much more likely to relapse to smoking. So obviously, if pregnant women do want to stop vaping, they should be supported to do so, and advised to get in touch with a stop smoking service or try nicotine replacement products or gradually reducing the nicotine in their vape. But it's important that we aren't pushing people to stop vaping too soon, because that increases the risk of relapse. And then in terms of the kind of impact of secondhand vapor, there's not a huge amount of evidence out there. There are some studies, but the evidence base is still emerging. So far, there is no evidence of harm to others from e-cigarette vapor, although it's possible that longer term exposure in enclosed spaces like cars or in a room might carry some low level risk to people who don't vape or smoke. So pregnant women could consider not allowing vaping in the home or car as a precaution. And obviously, babies have developing lungs, so you might not want to vape in enclosed spaces with newborn babies. But the key thing is that pregnant women and children are not exposed to secondhand tobacco smoke, which we know is extremely harmful. And often, smoking is often the alternative to vaping. So if it's one or the other, we would prefer vaping, but ideally don't do either around pregnant women or young children. And then that just gives you a screenshot of what the briefing looks like. So as I said, FAQ style includes suggested responses and supporting evidence. And there's a longer version, which is online only, but then there's a summary version, which is available to order. And the same for the infographic for patients. FAQ style has key information for parents and families and is available to order physical copies. And we've shifted tens of thousands of copies of these in the last few years. So there is real demand for this information to support professionals to have those conversations and make sure parents are informed. And I'm not going to linger on this. I just wanted to highlight there's a lot of incoming vaping regulations, both in the Tobacco and Vapes Bill, which I'm sure some of you have heard about, and the banning disposable vapes and increasing the tax on vaping e-liquids. And just to make the point that some of the, the challenges or the concerns people have around youth vaping or illicit vaping, lots of these will be addressed in the regulations that will be coming in the next few years. So we will have a much stronger regulatory framework around e-cigarettes in the near future than we have now, and that is something we absolutely support and encourage. And there are just some key links and resources, like links to evidence and useful guidance and training as well. So thank you very much. That's it from me. Happy to take any questions.
Thank you, John. It's really helpful to set the regulatory framework and doing some really good myth busting, really. I mean, the second hand around vaping was news to me, so really informative. And we will take all the questions at the end. And one question that I was very interested in is around all your fantastic resources if they come in other languages, given our diverse population in London, which we can perhaps address at the end. So last but not least, we have Caitlin Notley, who's a professor of addiction sciences, University of East Anglia. So welcome. Caitlin's going to talk to us about smoking in pregnancy, around the scale of issue and potential interventions in neonatal units. So Caitlin, over to you.
Great, thanks Nina, and thank you very much for the invitation to present today. So just check you can see my slides okay. Just give me a thumbs up.
Yes.
Great.
Yes, we
Thank
can.
you. Okay, so I've been asked to talk about the scale of the issue around smoking pregnancy. I'll skip quite quickly over that. We've covered that well by the expert speakers that we've already heard, and then talk to you a bit about potential intervention in neonatal units, which so far have been a relatively forgotten aspect in terms of our intervention around smoking cessation across pregnancy and the maternity pathway. So in terms of smoking prevalence, who still smokes? This is population level data from the Smoking Toolkit study. It's a nationally representative survey in England, asking people about their use of tobacco, cigarettes and other nicotine products too. So you can see clearly that we've seen, a year-by-year decrease in the levels of smoking prevalence at a population level, which is obviously fantastic. But still rates are relatively high. Around about 10% of adults are current regular smokers, and obviously this includes people of reproductive age, so it has an impact on smoking in pregnancy rates. But huge disparities in these rates of smoking prevalence. We see much higher rates of smoking in particular subsets of our population and particular geographical areas. So in terms of the disparities, it's estimated that actually women of childbearing age have a slightly higher smoking prevalence than the general population. So fairly old data now, but from 2018, around 20% of women of reproductive age were thought to be current cigarette smokers. Again, huge disparities in this data. The rates are likely to be much higher amongst people in routine and manual occupations, people of lower income or unemployed. And in terms of thinking specifically about families who have a baby who has an admission to a neonatal intensive care unit, we know those families are likely to be from particularly deprived backgrounds. So only 27.8% of families earning less than $25,000, this is data from America, reported having a total smoking ban in place during the time of the baby's admission. So it suggests that there's an association between smoking in families and having a baby of low birth weight, which of course corresponds to the data we've heard from previous speakers. But there's some really interesting things going on with tobacco smoking at a population level. This was some analysis that I collaborated with colleagues at UCL using again the Smoking Toolkit data. what it shows is an interesting pattern amongst women of reproductive age particularly. So whilst we've seen declines in tobacco smoking for women of reproductive age across the social gradient, and particularly important, we've seen quite a big decline, the top pink line there, amongst women of reproductive age in the lower socioeconomic categories, who obviously had the highest rates to start with. We've actually seen just in the year 2022 to 23 a slight increase in smoking prevalence amongst women of reproductive age in the higher income categories. So this suggests that there's something interesting going on about women of that particular age group, perhaps around social norms or cultural influence, that we really need to keep an eye on. Because of course, rates of smoking amongst women of reproductive age are going to impact on rates of smoking during pregnancy, when it's a critically important time for women to quit smoking. So we were interested to know about smoking prevalence of families of babies admitted to neonatal intensive care. We've heard that tobacco smoking is a leading cause of having a baby of low birth weight or giving birth to a premature baby. So it really kind of made sense that probably smoking prevalence of families who have a baby admitted to a NICU is likely to be higher, but we didn't really have the data to show this. So back in 2019, we did a brief survey. This was not very systematic. We just asked all the families attending the neonatal unit in my local hospital here in Norwich over a course of 4 months about their smoking prevalence. We found that about a third of mums who'd had a baby admitted to NICU were active regular smokers. About a third had recently quit or quit smoking during the pregnancy, so were recent ex-smokers potentially at risk of relapse. And then about a third were non-smokers or never smokers. And this was just the mothers that we asked, so it doesn't include data from fathers, who of course are really important influence in terms of family smoking. So some of the impacts, thinking about the impacts on very vulnerable preterm babies in particular. We know from data from America that smoking particles, that is the carcinogenic particles contained within tobacco smoke, have been found within neonatal intensive care units, despite them being extremely clean and sterile places. Swabs taken in neonatal units have found smoking particles on the furniture and even the incubators in the unit, suggesting that parents who smoke are probably bringing smoking particles in and out of the unit. And smoking chemicals were also found in the urine of babies born to parents who smoke, and this included formula-fed babies. So it's not just that tobacco smoking particles were being passed through breast milk of smoking mums, but also that babies were picking up on these tobacco particles if they were held or born to either a mother or father who was a current smoker. We know from evidence that babies born to smokers have longer stays on neonatal intensive care units, obviously hugely costly to the NHS, but also incredibly stressful and upsetting for families in this situation. And really interesting data, which is in a kind of an emergent area for research, suggesting that babies in neonatal intensive care units who've had greater exposure to smoking particles, perhaps throughout the pregnancy, also have less diverse gut microbiomes. And we know for premature babies that the gut microbiome is incredibly important in terms of their recovery and eventual ability to engage in normal life due to diseases that might be linked to the gut in later life. So we've heard that babies born to mothers who smoke are likely to weigh much less than those born to non-smokers, an average of 200 grams, and are at least at a 40% chance higher of being born preterm. So babies born to parents who smoke are more likely to need an admission to neonatal intensive care. Babies born preterm have extremely delicate lungs. Lung development is often incomplete, and many babies need very significant medical intervention, protracted respiratory support. These infants are particularly vulnerable to infection and would be particularly vulnerable to exposure to secondhand smoke. So secondhand smoke exposure in home environments increases the risk for babies going home of sudden infant death syndrome, also suffering respiratory conditions and other infections. So there's probably an additive effect for NICU babies who are already at high risk of these conditions, and if then exposed to tobacco smoke as well, are at even higher risk. And then we heard from Jane, of course, that there's an important preventative angle to supporting smoke-free homes for these very vulnerable infants, because children born to smokers are more likely to take up smoking themselves in later life. So quitting smoking for families who have a baby admitted to neonatal intensive care is a really important health behaviour change, and probably one of the few things that parents can actually take control of and do to significantly improve the long-term recovery and health of their offspring. It's obviously a really, really difficult time for families. We need to be incredibly careful not to stigmatise parents who may have smoked during the pregnancy, which may well have contributed to the admission to the neonatal unit. But we know from our qualitative work with families that parents in this situation are willing to think about smoking cessation, are amenable to change and to receiving support. But they are incredibly stressed. It's a really difficult time. They're not able to go and take up appointments to attend a stop smoking service. What they need is intervention there and then while their baby is on the unit. The NICU admission may actually represent a teachable moment in health behaviour terms for smoking cessation. It's a time when parents are thinking about the health of their developing infant, are often really desperate to do anything they can to improve health outcomes. And also parents spend a very, very long time on neonatal units, so develop really good relationships with the neonatal nurses, who are in a very good situation to intervene with parents to offer behavioural. So the only research we really have at the moment for parents in this particular setting comes from America. There have been some small trials offering nicotine replacement therapy and behavioural support with some evidence of effectiveness, and then also some evidence of effectiveness for using incentives in this setting. As we've heard from Jane, incentives highly effective for smoking cessation. There's no reason to believe they wouldn't be also effective with this particular population. But we do need more robust interventions that include focus on maternal and also partner smoking, and also thinking about the wider household, which is really important for the environment that the baby is discharged home to. So we were funded to do some work to develop an intervention to support families of babies admitted to neonatal intensive care. We did some reviewing of the existing evidence and qualitative work with parents and healthcare professionals working on neonatal units, and then some person-centred intervention development working with individual families. We developed a package of support which we called Love My Lungs. This is a whole unit approach to encouraging NICUs to be completely smoke-free and support families to be completely smoke-free. So the package of support has 3 parts according to parents' unique situations. Advice, guidance and support to create a smoke-free home environment from healthcare professionals working on the neonatal units. Direct support to parents to quit smoking, and also support for parents who may have stopped smoking during the pregnancy to help ensure that they don't go back to smoking. Parents of babies born and admitted to NICU are under huge stress, and there's a real possibility of relapsing to smoking at this time. So really important that we support parents to stay smoke-free. And the package includes training for NICU staff to be able to offer this support. So the support for NICU staff is based around a very brief advice model, the 3 A's approach, and really involves asking parents about their tobacco smoking status. Really shockingly, to date, we've had very poor data on parental smoking status of babies admitted to NICU. The patient in that situation is the baby, and often parents haven't been asked about their smoking status. So the first thing is identifying families who need advice and support, then advising parents about the risks to their baby's health of continuing to smoke or relapsing to smoking, and also the best way in which they might maintain a smoke-free home environment, and then acting, so offering support there and then while the parents are with their baby on the neonatal intensive care unit. We developed a package of training, which is a very brief online training for practitioners working on the neonatal units. This includes advice on prescribing nicotine replacement therapy while the baby is admitted, and also advice on using e-cigarettes or vapes as a way of switching away from tobacco smoking, which again might be a really effective way for parents who don't necessarily want to quit nicotine at the time of the stressful admission to be able to use nicotine in a less harmful way. We also developed a responsive website, which looks a bit like an app for parents that they can access on their mobile phones. As I said, parents are often in neonatal units for very long, extended periods of time. They can look at the resources on their phone. We developed a series of virtual reality style videos which show the impact of tobacco smoke exposure on preterm infants particularly. So this is all very, very targeted specifically at NICU families who wanted to know what the impact might be, particularly on their very small or preterm baby. So a range of resources we developed that we will be making available. And then finally, just to say where we're at now, unfortunately, we tried for a number of years to get further research funding to formally test this package of support via a randomised controlled trial. We haven't been successful. I'm really upset to have to report. I don't think it's that the funders don't think this is an important population. I just think it's the way that research funding goes, and we weren't successful in the particular funding streams that we applied to. So because a period of time has elapsed and we've done all this intervention development work, the next step for us is to make the package of support available. We're going to be doing that over the coming months and working closely to make sure NICUs across the country have access to these resources and have the support they need to offer support to families who may need help for quitting smoking and staying smoke-free. So thanks for your time. I'll stop sharing and happy to answer any questions.
Thank you, Caitlin. It's really great to hear the approach you have taken around recognizing is not the woman doesn't live, or the birthing person lives often within the environment and a family. So that family focus is incredibly important. So thank you. I know that a number of you have asked a number of questions. So I will, if I could just ask all our speakers, and I really need to thank you immensely for being absolutely brilliant with your timing, and that gives us a bit of extra time for Q&A, so thank you for that. And if I could just ask you all to put your cameras on, and we will, I'll go through the questions that are coming through. So I can start, I think, is my as a chair to start off, and my question is for you, John, as I mentioned before, in terms of your fantastic resources, are they available in other languages, and are there any plans to be able to make them accessible to our wider communities across London?
Yes, I went away and checked after you mentioned that before. So our vaping infographic, not the longer briefings, but the infographic is available in Bulgarian, Polish, Punjabi, Romanian, and Urdu, and we'll be getting the new one translated as well. And some of our other resources on CO monitoring and smoke-free homes are also available in other languages too.
Wonderful, thank you. So there is a question which is really pertinent to us in London, and that is from you, Tracy. With a prevalence of 3.9% smokers in London, which is below the national target of 6%, but with, as I mentioned, approximately 12 babies a day born to a mother who smokes, are we still keen to reduce rates of smoking? Is the national target likely to reduce? I suppose I can start, and I will invite other speakers to share their thoughts. Caitlin alluded to it, Jane has alluded to it, that although the smoking rate in London is quite low, but there are large disparities across various populations, and as we heard again around the variations across the social gradient means that we can't be complacent. And I think from my perspective, being a midwife, I feel we should not be led by the national target, but actually try to make sure that we can support families, because each baby really does count and each baby matters. So that will be my perspective. I don't know if other colleagues would like to share their thoughts and perspective on that, John. Thank you.
So I think, thanks, Nina. I think, so if you look at that 6%, the national target, that comes from the 2017 Tobacco Control Plan, which was a 5-year strategy, which is now expired. So what we would love to see is the government to publish a new strategy with new targets that take into account the fact that national SATOD is declining really quickly. And actually, that 6% target seems eminently achievable within the next few years. So I think the government should publish a new target that is more ambitious than 6% for the whole country.
Thank you. I couldn't agree more with you. Jane, can I bring you in there as well?
Absolutely. I think you hit the nail on the head there, Nina. I think it's not necessarily about targets, it's about those babies. And I think it's going back as a system, knowing even if, our target is reduced to 4% for Greater Manchester, even if you said 4%, you're already there. So I suppose, do people take the foot off the gas then and think we've actually done it? So I think it goes back to maybe for you is having a different look at that and looking where your babies are, where your interventions need to be, and reducing the number of babies and kind of putting the red herring that is SATOD to one side.
Thank you. Caitlin?
Yeah, of course, I agree. Even with reduced rates, there still continues to be parents who smoke throughout pregnancy, and we mustn't forget the impact on those babies. I think there probably will be a lowering of targets, but also to say, your SATOD rates in London and in Greater Manchester are fantastic. You've had really huge declines, but it's not the same across the whole of the country. In Norfolk, where I am, some of our coastal populations, we still have around about a 12% rate of smoking at time of delivery. So there's still a lot more to do when we look at the national picture, and we mustn't forget that.
Thank you. Tracy?
Yeah, and one of the so we have a low rate in London. And one of our issues is, well, you've kind of fixed it. You don't need to do anything. And that was one of the key drivers for having this week. So 3.9% is much better than 6%, but it still represents those babies and those mothers who are being exposed to tobacco that is harming them and their baby. So there's a constant in the world of tobacco, as you will all know, there is a constant well, we fixed this, let's move on to something else. And there is actually, it's our responsibility to raise awareness, which was one of the reasons for setting up this week. So
thank you, Tracy. Absolutely. And I think it's really important to say that the figures are slightly stagnating, and that's more of a reason for us to share the latest evidence around what the other options and the packages of resources are available to our expectant families. Caitlin, there's a question from you, I believe, is about how can we ensure pregnant women don't feel stigmatized for vaping as a way of quitting smoking, which is a really pertinent and relevant question. And I will come to John perhaps first, and then Peter. It'd be good to get your perspective on that.
So, sorry, how can we ensure people don't feel stigmatized?
Yes, using vaping, particularly pregnant women and or birthing people during pregnancy, if they are using it as a way to give up smoking.
Yeah, well, I think framing it very much within the context of anything they can do to quit smoking is going to be beneficial for their baby, and that includes vaping. And I think that's why it's so important that professionals have that evidence-based information to have those conversations, so that when people, inevitably ask, well, what about nicotine? What about this story I saw in the Daily Mail or saw in the media about vaping? They can address those concerns in a kind of calm, confident way to ensure that people aren't worrying like, what if this is just as bad as smoking? What if this is even worse?
Thank you. Peter, how do we share that fantastic evidence that you presented to us in a way that the public are aware of it and understand it?
I think there are two issues. There's whether women feel self-conscious and possibly ostracized if they vape and are seen as bad mothers. But the other thing is what they think about vaping and their own worries. And I think with that, advisors can do something. They can reassure them and explain the evidence and say, this is actually not harming your baby in any way which can be detected. I think advisors should have skills to address the main misinformation which is making rounds, like popcorn lungs and myocardial infarction, and I don't know what else is currently out there. We do every year with Robert West. He's not contributing this year. We do updates for Stop Smoking Service advisors on what's happening, and sort of practical advice and clinical supervision type of thing. And this year we do include how to address these common worries and misconceptions, so that advisors can actually do it in a way that is acceptable to smokers. So training probably for advisors.
That's really helpful. Thank you. And Jane, just wanted to hear your perspective, given that you have implemented a number of these packages. What's your experience in this area?
I think women come to pregnancy feeling stigmatized for smoking anyway. They feel judged. They feel like somebody's going to wag their finger. And I think really changing that conversation, starting with the CO, medicalising it, I think is really helpful. Talking about the high level of CO before you even get into treatment, and that midwife having a really good positive conversation of you're at risk, it might be your addiction to tobacco, and we've got this brilliant team, whoever that is, that's going to support you. And then vaping becomes a normal offer within that service. It's not something that's seen as something different. They're all devices of how to administer nicotine. So it's through a vape, through an inhalator, through a patch, through a lozenge, whatever that is. And it's just been routinely seen as part of the toolkit and not seen as something that's kind of demonized or something separate. And many women, like I said before, come to pregnancy vaping anywhere, that they're trying it, they've had a puff on somebody else's, they feel like, they want to use that as a device. So I think as long as we can normalise it and, like you say, use those evidence-based conversations and understand that predominantly this isn't their fault as well, because it's due to their addiction to tobacco. And I think we've really gone with the CMO quote that John showed, that if you're pregnant and you're smoking, vaping is far safer. And that's a quote they can then take away to say to relatives or friends and family who may challenge them. So it's empowering them to kind of have those discussions and to feel safe and secure in the treatment they're receiving.
That's really helpful. Thank you for that. And as you said, it's about awareness raising. And that's one of the reasons why we're here, both within the professional groups, but also the women and families themselves. So the next question is from David. David, thank you for your question. It says, what can you tell us about building that connection between midwife and health visitor and urgency for helping mothers to quit? Have you managed the smoking falling through the gap? So Jane, can I come to you, given that you have some experience in this, and I will take other colleagues' views on this as well?
Absolutely. It obviously, that relationship with health visitor and midwife, I think, has been quite something that been there for a very long time. Throughout my career, you kind of generally knew who your health visitors were with your community teams and had that engagement. And I think upon discharge now, we're getting better at making sure people leave hospital with the right information, going to the right people. So health visitors are becoming increasingly aware of those who are smoking, who they may be visiting. And I think what we've done is really encouraged our health visitors to come on our VBA training. So we've extended that training to our MDT teams that enable them to have the same conversation, have them that standardisation and consistency. Because I don't think it was until we did our kind of cross-system training in GM on baby clear and CO testing that midwives really had really excellent training on how to do a CO and how to have a good conversation. So I think bringing them into the fold and create that working relationship between the MDT team is essential. And obviously, when you've got an in-house maternity team as well, that kind of feedback, utilising the same systems to make sure that information is recorded and shared is really essential. And I probably think that's quite difficult for you guys with having the multitude of trust that you've got and different setups for health visiting services. But I think bringing everybody sometimes into a room, into a workshop, and figuring out how that works for you to get that information across is sometimes all it needs to open the door.
Thank you. And Caitlin, can I come to you, because obviously there is a neonatal unit is a really great environment to foster that collaborative relationship. And how have you managed that within the parameters of your interventions? Can you share your thoughts and experiences with us?
Yeah, it's been really interesting working with the neonatal units, and as I said, it's going to be a work, a continued work in progress. There's, culture change to be had with healthcare, some healthcare professional groups still. We've seen this in other settings like mental health settings, where perhaps healthcare professionals haven't really thought that intervening to offer smoking cessation support is part of their role, particularly on the neonatal units. The qualitative work we did with healthcare professionals, the nurses, quite rightly, very focused on the infant and its immediate medical needs. They don't necessarily see the wider family, the health of the family as part of their role. But I think, some education around the impacts of exposure to tobacco smoke for these very vulnerable infants being, discharged home has had a powerful impact and helped nurses to see that actually intervening with the family to create a better environment for the infant to go home to is part of their role. It's thinking about the long-term health and recovery of that infant, and also helping them to understand that actually they're really well placed to offer that support. Families who have a NICU baby are, often in a neonatal unit for weeks or even months. They develop really strong, close relationships with healthcare professionals. So they're able to have, quite personal discussions about health behaviours and would take advice from those people who they come to really trust. So it's those trusted relationships that can really make a difference. And we know from evidence that, having a healthcare professional even mention to you about the importance of quitting smoking can really make a difference. It's that kind of credible source of information. So really powerful position, and in a good place with a strong relationship with the parents to be able to offer that support. So I think it's just education for healthcare professionals so that they see intervention as part of their role and understand that they have a really key role to play.
Thank you. That's really important. And I think that you did allude to that as part of your talk around the teachable moments. So it really takes me back to every contact matters. And also with the development of the family hubs and actually bringing that wraparound support around the families and recognizing this is a long journey. It's not time limited, therefore, no matter where we are in the system as healthcare professionals, we have a duty and responsibility to continue supporting the families that we work with. So I was asking about data on women who relapse shortly after following the incentive scheme. Jane, do you have any data on that, or any other colleagues? Shall I come to you first?
Yes, I suppose we particularly don't look at our data in isolation from incentives, because obviously it is a whole system approach. We probably find the majority of women will relapse in that first 4-week period, obviously when they might not have the right medication or the right strength, or they've set on a quit journey when they maybe have got an event or something that they probably would be more at risk of smoking. But generally we find once we get the women past the 4-week quit mark, we get 75% of our women smoke free at birth. So it's kind of once you've got them in, they do stay smoke free. And the majority of relapses then occur in that first 6 weeks after having the baby. Obviously the initial kind of bubble of the first few days is there, but often if you're going back to a smoking household or a smoking community, some people might be going back socializing with different friends who smoke. Those opportunities to relapse and be tempted become more frequent, and also they feel a bit more confident in leaving the baby with others, or going and standing at the back door and having a cigarette rather than being in the room with the baby. So kind of those are the two pertinent points really. If we can get women to 4-week, great, they will stay with you, and like you said, that power of that advisor is key to that. And then obviously in that first postpartum period, hence why obviously through the national scheme we're offering 2 significant payments, obviously in the one, put my teeth in, at month 1 and month 3 as part of our postpartum element, and obviously that weekly support is there in that first 4-week period with incentives as well.
Thank you, that's really helpful. So Maya's got another question, but I believe that's been answered. That's around how do we get the research findings into the wider population, particularly around the safety of e-cigarettes. So if that's okay, I will move on to the next question, which is a very interesting one posed by David. What can be said for the health impact on fetus of those vaping but never smoked? Surely there is a larger cohort of this group in population now. What does the evidence say about nicotine from vapes? Peter, I'm sure you have some thought around that. Is that an area that you're looking into? Is there anything you can share with us in relation to this? Sorry, Peter, you're on mute.
I think there are some potential downside of using nicotine. I think it's better for pregnant women actually not to use it. So I would discourage never smokers from vaping during pregnancy. The risk will be very, very small compared to risks of smoking, but still, in pregnancy, you do better if you just avoid this. So my general advice would be, better if you don't. I wouldn't be panicking or would investing great amount of effort and funds to stopping people vaping, but I would advise against it.
Thank you, Peter. John, is there anything else you'd like to add? Obviously, you shared the quotes from Professor Whitty. Is there anything else in that space that you'd like to add to this?
No, I think I just entirely echo what Peter says. Vaping is an effective stop smoking aid. That is the context in which we would be recommending it. It doesn't serve any purpose outside of that, and may carry some low-level risk. So we would discourage anyone, including pregnant women, from doing it if they've never smoked.
Great, thank you. I know you have already answered my questions around the resources in other languages, so that's really helpful to hear. So thank you for that. And the resources will be hosted in a variety of websites to make sure that everybody can access them. There is a question, and you may be able to answer that, Tracy. Is there any directive coming from NHS England on vaping on NHS premises as means of quitting?
So I'm not aware of that, but the whole tobacco and vapes bill at the moment, and John, I think it's going to come in, has a number of sections about smoke-free spaces, some of which are quite controversial, some of which are less controversial, and so we'll look to see what goes into the final bill. Would you concur with that, John? Have you got anything to add?
Yeah, just to say, obviously, hospital sites are one of the places the government has indicated it will look at making smoke free in a legal sense, and we are in communication with NHS England at the moment around that. And I think our priority will just be making sure that NHS trusts get the support and guidance that they would need to implement that effectively, if that's what the government ends up proceeding with.
That's great, thank you. And there is a comment from Michelle. Thank you, Michelle, for your comment that this webinar comes at a great time as we are trying to ensure the last couple of trusts submit their operational assessment forms. So thank you to Tracy and her team for that. And there has been a number of other resources made available to you in the chat function. So please do take advantage of them, do share them with your colleagues and the families that you come in contact with. As we mentioned at the start, this webinar has been recorded. So if you would like to go back to it, particularly around the evidence presented by our experts, please do feel free to do so and do share it with your other colleagues. So I think it just remains for me to say, it's been a pleasure to be here. It's been incredibly informative. And even as a midwife, I have learned a great deal, particularly around vaping. So thank you to all of our speakers for the generosity to give us their time, expertise and experience, and I'm sure you'd be happy to. Some of you have kindly agreed to be contacted by others if there are further questions. And on that note, I just wanted to say thank you to everybody and thank you to our delegates for your participations and really engaging through your questions. And on that note, I wish you all a very rest of a good day. Thank you, everybody, and goodbye.
Thank you. Bye.